Hello, my name is Suzanne Cairn, Director of Healthcare Provider Engagement with the National MS Society. Welcome to MS and Rehabilitation, a comprehensive approach to care. I would like to acknowledge the Kansas-Missouri Healthcare Provider Council who developed the presentation. Today you will hear from Dr. Rola Mahmoud, who will be presenting on Module 1 Overview and Introduction of Multiple Sclerosis. The National Multiple Sclerosis Society is proud to be a source of information about multiple sclerosis. Our comments are based on professional advice, published experience, and expert opinion, but do not represent therapeutic recommendation or prescription. Any reference to a commercial or non-commercial product, process, service, or company is not an endorsement or recommendation by the National MS Society. The National MS Society does not endorse or recommend products, services, or manufacturers. The National MS Society assumes no liability whatsoever for the use or contents of any product or service mentioned.
Hello and welcome everyone. My name is Rola Mahmoud. I am a neurologist and a multiple sclerosis specialist at the Marion Block Neuroscience Institute, St. Luke's Hospital of Kansas City. We're going to have an overview of multiple sclerosis in the next couple of slides. We'll start today by having a better understanding of multiple sclerosis, its etiology, subtypes, and diagnosis. Let's start with an overview of multiple sclerosis. Let's meet Jack, who comes in to see you today at the rehab clinic. Jack is a 45-year-old man with a 6-year history of relapsing remitting MS. He was referred to the clinic for treatment of worsening fatigue. The patient first experienced bladder incontinence and weakness in both legs, which affected his ability to walk but resolved over the course of 3 weeks. The bladder incontinence persisted. He suffered another episode of weakness 9 months later, and an MRI showed a demyelinating lesion in the cervical spine at the level of C5. His lumbar puncture was consistent with MS. He was diagnosed with relapsing remitting MS. He had no family members with MS. He was given steroids for his relapse and was placed on interferon therapy. Over the years, he experienced 3 more relapses, each treated with steroids. He now complains of overwhelming fatigue, hip pain, foot drop, leg weakness, depression, constipation, and continued episodic bladder incontinence. He articulates frustration and overall dissatisfaction with the entire medical community because he had this disease and no one treated it right away. He reluctantly elaborates more on his fatigue when questioned. The fatigue has been present for 3 years and progressively getting worse. He generally feels refreshed after a good night's sleep, but fatigues by noon. Fatigue is somehow relieved by a nap. He is an attorney and generally works 8 to 10 hours, 5 to 6 days a week. He always takes work home and is completely exhausted, irritable, and can barely walk by the time he arrives home. He takes amantadine with a little benefit. He finds himself increasingly anxious at night and unable to sleep. Sleep is further complicated by his persistent leg cramps that prevent him from getting comfortable. His legs ache and feel especially weak at the end of the day. Some pain is relieved by gabapentin. He describes that he will avoid standing in court because he does not trust the strength of his legs and he does not want to appear weak. He describes that he limps and his left knee often buckles and contributes to falls about twice per month. He denies injury or anyone ever witnessing a fall. He tries to hide any signs of weakness or disability. His bladder always interferes with his work. He describes that he regularly rushes to the bathroom so as to avoid an accident. He admits to one accident while at work, and now he occasionally will wear an incontinence pad and always a change of clothes just in case. The physician prescribed oxybutynin, which does help. He just avoids all fluids at work to minimize the risk of those embarrassing moments. He feels that some of his MS symptoms have been gradually getting worse over time. So, what do we learn from Jack's story? Jack was diagnosed with multiple sclerosis at a relatively young age, 45 years of age. He was diagnosed with the most common form, the relapsing remitting form of multiple sclerosis, based on his clinical presentation, the clinical relapses that he experienced over the years, in addition to his MRIs and spinal tap. While he may not be experiencing any further relapses based on this story, but it seems like he's got a lot of issues, a lot of symptoms that have been bothersome and have affected his quality of life. So let's talk about what MS looks like and what causes MS. So multiple sclerosis is an autoimmune, inflammatory, and neurodegenerative disease that affects the central nervous system, in which axonal loss is the major cause of irreversible neurologic disability. It is the most common cause of non-traumatic disability in young adults in the US. MS patients have an imbalance in their immune system, where their immune system mistakenly starts attacking the myelin sheath, which is the covering of the nerves that run all over the central nervous system in the brain, spinal cord, and optic nerves. When this happens, the activated T and B cells enter the nervous system from the periphery and start attacking the myelin, leading to the various signs and symptoms that we see in people with multiple sclerosis. So the damaged areas develop scar tissue, which gives the disease its name, multiple sclerosis, which means multiple areas of scarring. When the myelin or nerve fibers are damaged and destroyed in MS, the messages within the central nervous system are altered or stopped completely. So why do people develop MS? We don't really have a clear understanding as to why people develop MS, but we understand that the disease is precipitated basically by a combination of one or more environmental triggers in a genetically susceptible individual. So you'll see that both environmental factors and genetic factors contribute to the development of multiple sclerosis. Research supports a genetic predisposition to MS. Over 200 immune genes are implicated in the risk of MS, which leads to an autoimmune response and demyelination. The various environmental risk factors that we know include timing and exposure to EBV infection. MS risk increases significantly following infection with EBV, and people with a specific immune-related gene and high levels of antibodies to EBV in their blood were 9 times more likely to develop MS than those without the gene and with low levels of antibodies. Vitamin D deficiency is another important risk factor. Cigarette smoking, whether active or passive, is an important risk factor. Another virus that was also implicated and has been shown to be involved in MS is the HV6, specifically related to triggering relapses. A team in Spain found that the HHV6 antibodies reached their highest levels in people with MS 2 weeks before a relapse. So increased salt intake, obesity in adolescents, and gut microbiomes are other risk factors. So when exposed to the right environmental triggers at the right time, an autoimmune response leads to inflammation and demyelination. So what is a genetic factor that we know? The risk of getting MS is about 1 in 300 for the general population, 1 in 40 for a person with a close relative with MS, which means a parent, a child, or a sibling, or 1 in 4 for an identical twin, which is 25%. 20% of people with MS have a blood relative with MS, and sometimes you see these families that come in with several family members with the disease. So MS is usually diagnosed between 20 and 50 years of age, but that being said, we sometimes see it in young children and older adults more than 60. It is more common in women than men with a ratio of more than 3 to 1, and some studies show the ratio could be as high as 4 or 5 to 1, which could mean that hormones may play a significant role in susceptibility. It is most common in those of North European ancestry, but all races can be affected. It is more common in Caucasians than Hispanics, and research has shown that the risk in African American women may be equal to that of Caucasians. It is more common in temperate areas the furthest you go from the equator. So when people present with multiple sclerosis, it is very important to understand whether they're experiencing a true relapse or a pseudo relapse. A true relapse is also called an attack or an exacerbation, and that means basically the patients develop new or increasing symptoms over the last 24 to 48 hours, and they are not accompanied by fever, infection, or an illness, and that means they're having a new attack or a new lesion that's causing their symptoms. Whereas a pseudo-relapse is any symptom or reemergence of symptoms that usually lasts for a short time, less than 24 hours, and it doesn't leave any damage behind. Usually it's triggered by either an underlying infection, such as a urinary tract infection or flu-like symptoms, or sometimes by increasing the body's core temperature with exercise or fatigue, or increasing stressors sometimes can bring on the symptoms. So it is very important to tell our patients that if you are exposed to heat for a long time, or if you have a fever, or if you have an underlying infection, if you're doing a lot of exercise, you may experience re-emergence of your old symptoms, and that does not mean that your MS is active and you're having new symptoms. But that means you need to slow down a little bit, you need to let your body cool down, or have your infection treated by your primary care physician, and your symptoms will hopefully get better. Now, as you can see here, there are different types of multiple sclerosis. The most common form in about 85% of patients is the relapsing remitting form, where people experience a relapse characterized by full recovery or sometimes residual deficits in between relapses. And then comes the secondary progressive form, where if people with relapsing remitting forms are left untreated for a long time, they may develop the secondary progressive form, where they have continued worsening with progression of disease, with occasional relapses and minor remissions and plateaus in between. The primary progressive form is the least common form, and people here continually experience worsening symptoms over time. Clinically isolated syndrome is another form of multiple sclerosis where people develop a single attack and have an increased risk of developing another attack, or they can be actually diagnosed with MS if, depending on their MRIs and LP, if they meet the diagnostic criteria. So, how do we monitor the disease? People are classified as being active or inactive depending on whether they're experiencing any relapses, whether they have any MRI changes, such as new lesions or contrast enhancing lesions on their MRIs. They're considered to be progressive if they have a slow, gradual decline in function. So, we can now classify patients as having a type of MS, like the relapsing form of MS. We can further classify them into active or inactive, progressive or non-progressive, both or neither. So how is MS diagnosed? In multiple sclerosis, there's actually no single test to make the diagnosis of MS. It is basically a clinical diagnosis made based on the clinical history suggestive of multiple sclerosis relapses. It is based on the signs and symptoms that patients present with that have to correlate anatomically with their MRIs. It is also based on other supportive evidence such as spinal tap results and MRIs, again, including other non-involved parts. So we've got some diagnostic criteria called the McDonald's diagnostic criteria that help us with the diagnosis. And these criteria require that patients have dissemination in time and space based on their MRIs. That means they have different plaques in at least two separate areas of the central nervous system, and that these plaques have occurred at different points in time. What is also important is that we have to rule out other multiple sclerosis mimickers, and there must be no any other explanation for the patient's symptoms to make a diagnosis of MS. So the symptoms of multiple sclerosis can be very unpredictable. They are variable and depend on the areas affected of the central nervous system and the amount of nerve damage. So again, some of the symptoms may be visible, like the ones pointed out in orange, or sometimes they can be invisible. Sometimes people may experience one symptom or two of the symptoms, and sometimes their disease could be mild or severe depending on, again, which parts of the nervous system are affected and the variable degrees of disability left behind from these attacks. Fatigue is one of the most common symptoms of multiple sclerosis, which could be multifactorial, could be secondary to MS itself due to impaired nerve transmission, or could be secondary to other factors such as bad sleep, polypharmacy, pain, waking up in the middle of the night because of neurogenic bladder. And so you'll see that we are going to encounter other symptoms over the course of our discussion, and there are a lot of treatment options for patients to treat almost all of these symptoms. Again, the ones that we see here are the visible symptoms. The ones in orange are the visible symptoms. But remember, a lot of the symptoms can be invisible and can affect the patient's quality of life significantly. So it's very important to address these questions. Depression is also one of the most common symptoms of MS, and it can be very frequent in people with MS than the general population or any other chronic illness. So disability in clinical trials is measured by a scale called the EDSS scale, which ranges from 0 to 10, where patients who score 0 have a normal neurological examination, and the higher scores on the scale indicate more disability progression. So someone with minimal disability may range from 0 to 2, and as they continue to need assistive devices, their scores go up higher, where patients have increased limitation in walking ability as a score of 4 and need assistance for walking when they reach a score of 10. Again, this is the gold standard, but we do not use it in everyday practice, and it has limited sensitivity in rehab. So what do we need to know about the EDSS? It's basically a scale that is used to quantify MS disability and provide common framework to describe client status. It is used basically in research studies to classify subjects. It assesses several functions, including the pyramidal functions, cerebellar, brainstem, sensory, bowel, bladder, visual, cerebral, or mental systems. And why do we use it? Because it's considered the gold standard in standardized testing. Again, it helps PT, OT, and speech therapists use the information to determine how their patients compare to the study sample, so that they can help them with decision making when generalizing the study's results. But there are some challenges to the scale, which include the questionable reliability, validity, and sensitivity, particularly for small changes. So this slide and the next slide are here to show you the many cases of MS, any of whom could need the services of a mental health professional. For example, Julia is a 35-year-old wife, married mother of 3, who is exhausted all the time and can't drive because of vision problems and numbness in her feet. Jackson is a 25-year-old African-American man who stopped working because he can't control his bladder or remember what he read in the morning paper. Maria is a 10-year-old Hispanic girl who falls down a lot and whose parents just told her that she has MS. Loretta is a 47-year-old white single woman who moved into a nursing home because she can no longer care for herself. So this tells you that it is very challenging to work with patients with MS, and sometimes you really have to have an understanding of what's going on in their life and what's causing their most bothersome symptoms to be able to help them the most. Sam is a 45-year-old divorced white man who has looked and felt fine since he was diagnosed 7 years ago, while Karen is a 24-year-old single white woman who's severely depressed and worried about losing her job because of her diagnosis of MS. Sandra is a 30-year-old single mother of 2 who experiences severe burning pain in her legs and feet. And Jeanette, whose tremors are so severe that she cannot feed herself. So now that we've talked about the common MS symptoms and the visible and invisible symptoms, how would you approach Jack differently now that you know more about MS? Clearly, MS is a disease that does not only affect function in terms of weakness in an arm or a leg, but there's more to the disease, other symptoms that can bring on or worsen these physical symptoms. So it's very important to have an understanding of the other invisible symptoms, such as bladder issues that can keep them up in the night and can contribute to their fatigue or worsening depression. So it is very, very important to ask those questions and tailor your treatment based on the patient's symptomatology and most residual and bothersome symptoms. So to summarize, multiple sclerosis is a chronic demyelinating disease of the central nervous system and a leading cause of non-traumatic disability in young adults. The cause of MS is unknown, but is believed to involve interactions between genetics and the environment. Risk factors include smoking, low vitamin D, obesity, and timing of EBV exposure. MS is commonly diagnosed in 20 to 50 years old people and is more common in women. MS can be relapsing remitting, which can evolve to secondary progressive or primary progressive. MS is diagnosed based on history, imaging, and lab workup. A relapse is a new or increased symptoms that last at least 24 hours. A pseudo-relapse is transient worsening of old symptoms due to stress, heat, or infection. And remember, MS is diagnosed based on the history, imaging, and lab workup aid in the diagnosis. Thank you for your attention and have a great day.
Our goal is that as a result of participating in today's program, you will plan to change your practice or behavior by utilizing the National MS Society as a continuing education resource, incorporating the National MS Society resources into patient education, and increasing engagement with the National MS Society. Engaging with the National MS Society is the best way to stay informed of how we can be your partner in care. You see on the screen is a staff contact and MS Navigator and how you can connect to the Navigator. Please complete the survey link before leaving the presentation. Thank you.